You're listening to Don't Tell Me to Relax, the award-winning, no-nonsense, always friendly, down-to-earth fertility podcast. I'm Hannah, a fertility acupuncturist and big believer that fertility care and education should be better. Each week, I sit down with a guest to share real stories, advice, and honest conversations to help you feel better informed. And for care and connection, we have our Don't Tell Me to Relax online fertility community and our clinics in London and across the UK. To find out more about getting involved and working with us, the details are in the show notes. Don't Tell Me to Relax is proudly sponsored by the lovely people at Acupips. Acupips is the original ear seed company founded by acupuncturist Zoe Young. Ear seeds are tiny seeds or metal beads attached to an adhesive and placed on pressure points in the ear. They're brilliant for calming the mind, easing anxiety and restoring balance. We use them in our clinics all the time. Head to acupips.com to find out more and use the code RELAX for 20% off. Welcome to today's episode of Don't Tell Me to Relax. I am joined by Mr. Bill Smith, OBE today. Bill is head of CDS, Clinical Diagnostic Services, Ultrasound, and is recognised internationally as a specialist ultrasound practitioner with particular skills in areas of gynecology, reproductive medicine and pregnancy. Bill is highly regarded for his scanning expertise and clinical knowledge, and we must have sent I don't know how many people to see you, Bill, over the years of practice, but I know you are used by people in my team and beyond far and wide because you have excellent skills in diagnosing and really supporting our patients. And Bill is with us today to share his knowledge and expertise on the advantages of cycle monitoring. So we're going to be discussing cycle monitoring if you're trying to conceive. So Bill, welcome to the podcast. It's so lovely to have you here today.
Thank you very much. And thank you for those kind words.
So Bill, can you start by telling us, before we get into cycle monitoring, I would love for you to explain to everybody the journey that you've been on, your years of practice and how and why you work in this field.
My interest has always been mainly reproductive gynecology, and that means that the emphasis was on not just looking at improving couples' fertility, but working with the couples and also screening out the kind of gynecology or gynecological issues that would affect fertility. So that was the background. Eventually began working with a chap called Professor Ian Kraft, and we developed probably what was the largest IVF unit in the UK at that time. In fact, we were the second unit in the UK with an IVF pregnancy, the first with twins. We're beaten by another group, but we won't mention them. And, the relevance is that unlike other IVF units, past and present, Professor Kraft wanted his unit run on advanced ultrasound scanning. And I was very involved with developing ultrasound imaging technology. And we worked together with the rest of his team. We would see, there were days when we did up to 20 egg collections in a day. Today, most units wouldn't do 20 in a month. But the major issue was, or aspect was, everything was based on ultrasound. He didn't rely at all on blood tests, as most units do. It was all to do with modern state-of-the-art ultrasound. And along the way, together we developed internal scanning, transvaginal scanning, which revolutionized gynae diagnosis and certainly had a major impact in terms of infertility. And together we also performed the first transvaginal egg collections, which is now routine around the world. Now, the relevance here is that so we had state-of-the-art, modern, advanced ultrasound technology, but it was being used in an IVF sense. And I wanted to take that into more natural cycles. Probably since in the last 45 years, I've probably monitored probably tens of thousands of natural cycles. And that's provided me with a wealth of experience and expertise in looking at reproductive physiology and also looking at gynecological factors which physically, anatomically affect fertility status. So as a result of that, I developed clinical diagnostic services, CDS, and this team has been together now for 20, 30 years. We've been recognized worldwide for the work that we do. I feel that the strength of our unit really lies with the fact that we work with the patients. We are dealing with natural cycles and we work very, very closely with the patients. And that's how CDS developed.
So, can you explain to us why you would suggest somebody does cycle monitoring, and how is it different from a regular transvaginal scan?
Well, a lot depends on who does it and what kind of technology you're using. I'm sure patients are aware that you can pay up and go for a so-called day visit to have a fertility screen. Now, the cycle is complex. The cycle is very dynamic. That's the first point I would make, is that if we're monitoring ultrasound or monitoring fertility in terms of ultrasound, a single scan is not adequate. It's not adequate. It's a very, very limited amount of information that we can gain at any stage of the cycle, and very often it's misleading. We've worked on the basis of developing what we would regard as comprehensive. We use the term comprehensive cycle monitoring, where we take patients through a complete cycle, obviously, and we would do 3 or 4 scans. They should be relatively quick scans, and also uh, patients have a life outside of our unit, so we're very aware of that. So we work with the patients. We have a flexible timetable. We work to the patient's convenience. We don't cut corners. You can't cut corners in this game, but we can make life a lot easier for the patients in terms of this, what I term flexibility. And as I said, it means that the patient would have probably 3 or 4 scans at one of our locations. The scans basically involve a very, very early assessment, say around day 5 to day 8. This is a good time to check for any gynecological disorders, any anatomical disorders that would prevent conception or would affect the development of an early pregnancy. And then we would follow that up with a couple of scans. If we look at the textbook 28-day cycle, we're probably talking about somewhere between day 12, day 15, where we would watch the ovarian follicles develop, and we would confirm when ovulation is likely to occur and has occurred. And this isn't a matter of just looking at follicles or measuring follicles. We look very, very detailed into the follicles, the vascularity of the follicles, and also very important, the effect the follicles have on the lining of the uterus. So when we're talking about ovulation, monitoring ovulation, we're very, very focused on not just the ovary and the ovarian follicles, but very much so on the lining of the uterus, the endometrium. So they're the first 2 or 3 scans. And then very, very important is we will then do a scan about 8 days after ovulation. And this is to look at progesterone factors. We know that it doesn't matter how healthy a pregnancy might be, how good an ovulation might be. If progesterones aren't good, then the patient will go into a period without knowing any different. We don't do progesterone blood tests. Progesterone blood tests can be very misleading. They might give you a level, but they don't tell you that 3 days earlier the level was much higher and the levels are on the way down. Also, looking at thousands and thousands of cycles, it's obvious that different patients need different levels of progesterone. Our machine will tell us what kind of levels of progesterone we're looking at, but the focus is really on the lining of the uterus. The progesterone doesn't thicken up the lining. People think it does. It doesn't thicken up the lining. It keeps the lining there. The nice lining that's produced by a good ovulation, the progesterone keeps it there. So it's very important that we do this when we do this late, what's called luteal phase scan, which other units would be focused on doing blood tests for progesterone. We are focused on the lining of the uterus. We want to compare the lining of the uterus then with the lining of the uterus around ovulation. So that kind of, if you like, briefly summarizes what a monthly cycle is. We can add to that. We can check the tubes. We developed the technology, the ultrasound technique of checking your the fallopian tubes. We also initiated the technique of introducing saline into the cavity and producing virtual 3D imaging of the cavity, so look at the healthiness of the cavity, and we can put these special procedures as part of a monthly cycle. So you can see it's a very detailed exercise, a detailed program, and that's why we call it a comprehensive monthly cycle. So it's not just doing a scan here or there, it's thinking things through, working with the patients, explaining everything to the patient, and hopefully at the end of the day, achieve a pregnancy. If we don't achieve a pregnancy, at least we obtain a wealth of information that's of considerable value in terms of moving on into other techniques, other areas of infertility if need be.
And who do you think is a good candidate for doing cycle monitoring?
That's such a good question. You see, our relationship and our discussion with patients is very important, very important. And we explain this to the patient. You take a couple who decide they want to have a baby. I think it's accepted statistic that most couples will conceive within 6 to 9 months. Some will be lucky and conceive straight away. Some it will take longer than a year, but we have to accept that some won't achieve pregnancy. So when we apply this type of program, cycle monitoring, it follows a similar pattern, and when patients come through, some will conceive first month. But others, probably, it peaks at somewhere between around 3 to 4 cycles. And we have to accept that some don't get pregnant, but we've amassed a wealth of information, and we can pass that on to colleagues as we pass the patient on to IVF, for instance. It's all very personal, and it's as much emotional as it is clinical. So it's really a matter of working with the patient and kind of gauging with the patient how far down that line they're willing to go. But that's the kind of background to the patients that we see, the patients we deal with, and the kind of process that they go through.
And we often discuss on the podcast this idea that we don't diagnose women in enough detail to really support their fertility. So I often give the example that you see a GP for 5 or 10 minutes and then you're referred directly to a fertility clinic. And usually that referral results in you doing IVF and you have a scan, some blood tests, and off you go for IVF. But this bit of diagnostic research is not really done anywhere that I come across, which is why we send so many people to you. Why do you think we are in this situation of not properly investigating women?
Well, it's easier for a GP to send the patient up to an IVF unit, administratively, clinically, to offer the patient the kind of service that we offer. It takes time, it takes thought, and I'm afraid that system just isn't there generally. And it's sad. It's sad for the patients, and this is why so many patients are passed on to IVF. I got out of IVF for two reasons. First of all, it's too commercial for my liking. You remember that most IVF units are now run by venture capitalists, not by doctors. And also, we've shown that there are too many patients having IVF who don't need IVF. They can benefit from a more natural or less invasive approach. And also, the big thing is that with the monitor cycles that we carry out, we're actually working with the patient. The patient is part of the team. We achieve success not because of the fact that we are lucky, we have state of the art machinery, we have lots of scanning experience within the unit. We have success because we work with the patients and the patients work with us. And the patients aren't given that opportunity in the wide world, unfortunately. And so this is why Hannah is very aware that there is an overuse of IVF. And you have to remember that more patients fail at IVF than win at IVF. But we have to say it's a very lucrative business.
And do you think that lack of diagnosis and understanding of people before they go into IVF contributes to those statistics around the outcomes?
There is a definite lack of understanding. One of the reasons we enjoy working with people like Hannah and other, what we term integrated healthcare professionals, we feel that that's the term that give acupuncturists, homeopaths, or osteopaths, give it the credit that they deserve, is they realize the complexity of the body and they realize how important function is. They see things point of view. And really, the work that we do, looking at function all the time, the patients actually understand more about function when you inform them than really kind of telling them, what an ovary looks like, what the myometrium looks like. Yeah, they understand function. And I think this is a big failure at the moment where a lack of, not just a lack of recognition by the medics, but a lack of knowledge. And, uh, and also, if patients go to a fertility unit or an IVF unit, what I have to remember is it would be very unusual for the patients to benefit from the type of ultrasound technology that we have or the scanning expertise that we have. And I would defend the statement when I say that ultrasound is performed very, very badly in IVF units. IVF units get off the hook because if things don't go wrong, right, they will always blame the patient. They will tell the patient, your eggs are too old, or you didn't respond to the stimulation. They will tell you that the medication they gave was inadequate. They will tell you they took the patient to theatre too early and the eggs were immature. They will tell you the embryologists were having an off day. So we approach the concept of fertility treatment in a totally different way to so-called fertility units. But the major factor is the patient, not just in terms of the person you're treating, but the involvement of the patient and the way the patient comes to terms to understand what's happening and works with us, and we achieve success that way.
So, if somebody is doing cycle monitoring with you and you find that they have an issue, let's say with their luteal phase, which is very common, we see it a lot. What are your next steps? So, on a scan, you think the endometrium isn't looking as good as we would like it to look at this stage. What treatments do you offer at that point?
Uh, we we use progesterone,
Okay.
progesterone suppositories, and we've been using progesterone suppositories now for 30, 40 years. It was an interesting story. I was in 1982. I was in a meeting with a world famous endocrinologist, IVF consultant named Ian Craft, an IVF consultant from rural North Shore, Sydney, and we were talking about progesterone in IVF. And I actually approached the group and said, well, why aren't we interested in progesterone in natural cycles? And with their encouragement, I have to say, with their encouragement, that's how we really started on this road of focusing on progesterone. We are the first, we will be the first to say that progesterone is not the answer to everything, but we've had tremendous success with using progesterone. We don't know. We don't know. We have to say that. If we'd given the patient Smarties, maybe we'd got the same result. I very much doubt it. But we're not academics. We are hands-on practitioners, the same as Hannah. And I'm not going to sit there and write evidence-based uh, papers or make up evidence-based papers to get me a PhD. I've got my OBE, that's good enough for me. And you just kind of owe it to the patients to be honest and work at these things. When we talk to patients, we say that, we have lots of pregnancies coming through, but we have to be honest and say, we do not know why. We do not know why patients had to come to places like this to get pregnant. And patients need to know that. Patients get the idea that we know everything. We don't. And everyone has something to offer if the world will listen to them in terms of patient care and fertility care. And that includes the patient. I've got a lot on my chest talking to Hannah. I hope she's not going to charge me for this therapy session.
So, Bill, we see a lot of people now being diagnosed more with adenomyosis. It's something that is picked up a lot more for people on scans. What are your thoughts around adenomyosis and conception?
We've been looking at adenomyosis now 30 years. I wrote a chapter in a book, a leading book on endometriosis called The Atlas of Endometriosis. And in that chapter was, all those years ago, was a section on adenomyosis. Adenomyosis is actually difficult to prove from a histological point of view. The disease can be quite diffuse through the myometrium. And even if you do biopsies, even if you do a hysterectomy and you slice through the uterine wall, you can still miss the areas of adenomyosis. But what we've really learned is, although we're not sure about the etiology of adenomyosis and endometriosis, but what we do know is that there are things about adenomyosis that can affect fertility. And the two main factors would be pain. We all know that adenomyosis causes painful periods, but also pain on intercourse. And we know there are couples who can't have intercourse properly because of adenomyosis. But also, in severe cases, if it affects the endometrium. And we've shown the effects of severe adenomyosis on the endometrium for decades now. Now, for some reason, last couple of years, I've seen lots of people jump on the bandwagon, and you probably find that adenomyosis might well be overdiagnosed now, which you can blame us for that. But it's a complex disease, and we have to kind of work with it in terms of trying to get the patient pregnant or around the effects of adenomyosis. Now, endometriosis in the pelvis, again, it's a complex disease. It's a complex disease. We can see patients and there are, it's grade 4 endometriosis. There's everything. There's endometriotic cysts, there's nodules, there's adhesion. Those patients might not have a symptom.
Mm.
It's an incidental finding. We can have a patient where we can't see the endometriosis, but the endometrium starts off in the deep pelvis. And if you look through a laparoscope, it's like looking at freckles. You're not going to pick up a freckle on an ultrasound, but you're going to have a few freckles of endometriosis, and that patient would be in immense pain. It shows you the complexity of the disease. And again, we're not sure about the etiology, or we're not really too sure about the disease process itself. But we do know that there are things that we can look at, things that we can do to improve the situation for the patient, not just from a fertility point of view, but obviously from their quality of life point of view as well. There's a big thing now in the world of ultrasound, people going off on courses to learn how to scan for endometriosis. Well, it's a pity really, because anyone doing decent ultrasound should be doing the checks anyhow. The checks that people are taught now in terms of identifying endometriosis, it should be done anyhow as part of a routine pelvic scan. You say, kind of, what's the difference between what we do and a routine pelvic scan? Well, a routine pelvic scan should accommodate all of these things.
And just going back to adenomyosis, Bill, what are the treatments recommended for it if you find a significant amount of adenomyosis and somebody is trying to conceive? Is it about having extra progesterone support? What would be your kind of
Well,
recommendation?
certainly, obviously, I'm not a medic, and I'm really kind of talking out of turn here. But when you look at adenomyosis generally, obviously, it's very hormone driven, estrogen driven. So the use of progesterone is tremendous benefit. But
Mm,
obviously, you have to balance that with the fact that if you suppress the estrogen activity within the body, you decrease the fertility level. So it's a difficult area, and I'm not quite sure if the world has come up with the answer to that.
yeah.
So it leaves us in a situation where, at least for the time being, we can at least try and work around these things and try and to kind of get a better endometrium by using our estrogens. Maybe we can kind of stimulate the ovaries despite the presence of endometriotic cysts. It's a matter of trying to work around these issues if we're trying to preserve our fertility at the same time. It's a complicated scenario.
And Bill, can I ask, where do you stand on the use of ovulation predictor kits? Because obviously you do a lot of cycle tracking, so you can see much more clearly the time from follicle development to actual release of the egg. Do you think ovulation predictor kits are helpful,
I,
or
u-
do we
I
proceed
use
with caution?
I use them all the time, Hannah.
Okay, right.
Now, we're actually, if I've had this conversation today with two patients already, great when ovulation kits work, but they don't always work.
Yeah.
But we encourage self-testing. I think it's great if a patient can use her pee on sticks or whatever, if she's checking temperatures and whatnot, then she can see on the screen, hey, it ties in with ovulation. It's great. And that means that there's a better chance. If she knows it works for her, then it means that maybe she hasn't got to come to places like this. And we encourage that. The thing that we do kind of stress, though, and as I've had this conversation twice today already, we find patients kind of starting self testing around day 6, something like that. And they're not ovulating till day 18, day 22. And that's stressful. We say patients, look, you're coming through a monthly cycle. We would encourage you to do self testing, whatever means you've been using, but don't use it until we tell you you're a couple of days away from ovulation. So you're only using it for a short period of time, but you can see if it works for you. And I suppose while we're on it, it's the same as uh, with intercourse. We see patients having intercourse every other day from kind of day 6 onwards. It doesn't work. It doesn't work. And again, we'll say to couples, just normal sex life, whatever normal sex life is for you, that's how you start off in the cycle. Then again, once we get closer to ovulation, 2 or 3 days of ovulation, then we might become a little bit more clinical and say, abstain from now, so on and so on. Use your pee on sticks or whatever, and then we keep in touch, we work together, and we pinpoint when ovulation occurs. Well, it's not really when ovulation occurs; it's when the fertile window is. We're not quite sure how wide that window is. I think from years and years of doing IUI, it's likely to be at least 12 or 15 hours either side of
Mhm.
ovulation. We're not quite sure it's the honest answer to that. And different people have different views. But that's how we work about. We would encourage patients to do self-testing. But we do stress it doesn't work all the time. It doesn't work all the time. But there again, our ultrasound doesn't work all the time, or else everyone would be pregnant. So we have to be honest.
And Bill, there are lots of ultrasound places up and down the country who offer fertility MOTs, fertility checks. If somebody is, if they can't access your clinic, how would you advise somebody to make a choice to ensure they were with a good clinic? Because from when I've listened to you speak, it sounds like there is a range of skills in the world of sonography. How do you choose a clinic that you know is going to be good?
I'm really sorry to say this, and it does sound arrogant, but we are leaders in this field,
Hmm.
and patients deserve better than they get within the UK, around the world, in terms of cycle monitoring. And this, I try not to use this fertility MOT. If you go for a fertility MOT, even if it's done well, even if you come to us and we do, what can you do on one day? As I said, the cycle is dynamic.
Mm,
You know, you when we do a scan in the first week of the cycle, we're looking at totally different things to when we're doing the scan in the last week of the cycle. Uh, and uh, uh, and it's a lot of people. Maybe this is a chip on my shoulder. I don't know, but a lot of people are making a lot of money out of so-called fertility MOTs, and it's really an educational thing. Units should be educated. More people should be educated in terms of how they treat. This is what is nice about dealing with integrated healthcare professionals. Don't see patients just once. They look at changes. They look at the changes, the physiological, the functional, the hormonal changes that occur within the body over the course of 4 to 6 weeks. And yeah, there is no way in that 4 to 6 weeks where you can see someone on a certain day and then that gives you the information. And it's not just a matter of the limitation, the limited information it offers. It's fun. It leads to misdiagnosis. I'm sure I've never heard the term MOT from from an integrated healthcare professional. We come across it lots of times from fertility units and doctors and sonographers, but not from integrated healthcare professionals.
mm. And Bill, do you get many people who come to see you after they've been through IVF and IVF hasn't been successful? Do people come and try a different approach subsequently?
Lots.
Lots.
SVS.
Yeah.
We have a number of patients with close pregnancies and that have been for IVF and IVF's failed. We have patients who are pregnant who are on their way to IVF.
Mm,
Also, too, we have patients who end up having IVF. We must be honest and say that. But this is why, as I said before, I got out of IVF because there were too many people having IVF who didn't need IVF. And there's lots of kind of peer pressure in certain groups, certainly in London. And if they haven't had conceived within, say, 3 months, we get ridiculous statistics like that. They're pushed off to IVF. And certainly the downside of that was lovely when they get pregnant, don't get me wrong, but the fact that an IVF kind of sees a group of patients who don't really need IVF, and they all get pregnant. But of course, it goes into their statistics, and it helps to promote the use of IVF.
mm.
And that's the way we feel. Probably if I'd stuck with IVF, stuck with Ian Croft, God bless him, wherever he is now, I'd probably be driving around the south of France in a Porsche. I wouldn't be sitting here talking to the lovely Hannah, would I?
Well, we're grateful that you didn't do that, Bill, because then we wouldn't have someone so good to
You
send
you
it
you
to.
you might be Hannah.
Well, I am.
Okay. Well, hopefully that's not too kind of over the top in terms of we are controversial figures. We're the first to admit that. I'm the first to admit that I'm not very popular in the world of IVF and medical circles. But I love being part of the integrated healthcare profession.
Well, Bill, thank you so much for your time today because that has been a real insight. And I think the idea of better diagnostics, whether it's for male or female, is definitely something that I see changing a lot. And people aren't necessarily always going straight for IVF these days. I think this message about better investigations before you go down that road is starting to come through louder and clearer. It's been really, really helpful to hear your take on that today. So thank you for your time. It's very
Okay.
appreciated.
Thank you very much. It's been a pleasure. Thank you.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.